Hi, it's Dr. Centeno, and thanks so much for joining us. Just for a little discussion today about PICL outcomes, as well as Q&A on Facebook and on YouTube. The goal today is for me to go through about 10 minutes of didactic information, in this case on the outcomes from PICL procedure. And this is just a review of 1 month of patients walking through the door. And then we'll get into Q&A. On the Q&A side, you can ask me questions about this topic or really any topic at all, whether that be craniocervical instability related or related to regenerative medicine or pretty much anything else. So again, we'll do 10 minutes of this. Topic today is a review of 1 month of PICL patients seen in the office. And then from there, we'll get into Q&A. And this is a project I started because I was trying to keep track of these patients from the standpoint of trying to encourage them to repeat their DMX studies. And as I did that, I started to collect more and more information as they walked through the door. And as I did that, I started to get the sense of, this gives me a nice way to sort of record some additional information on each patient. So I started then collecting information about the outcomes they were reporting. I started collecting information about how well each procedure went, whether or not their anatomy during the procedure was different that could have affected outcomes, etc. So long story short is that then progressed to having a list of patients from the last month and their outcomes. And then in addition to that, I've committed to do this now until the time I leave on sabbatical. So that's coming up on May 2nd. So I should have another 2 or 3 weeks of this posted on the PICL Reddit as that becomes available. So I've just been updating it every week. So let's get into this as people start to join. So this is a review of 1 month of PICL patients seen in the office. So PICL outcomes. We put online 2 PICL outcome analyses. We're writing a third for publication. I shared this research plan on the PICL Reddit sub. And in the meantime, I've been, again, recording all these patients who returned for additional care as part of another project. So if you haven't had a chance to join the PICL sub, I would do so because I do things like share research plans and say, hey, are there other things that might be interesting that we're not looking at as we analyze all this information? So I kind of went through this in my head this morning and then double checked some things online. And the question was, is anyone out there who's offering care in this patient population in CCI, whether it be injection or surgical care, publishing their outcomes either online as they go or in medical journals? And, this is what I came up with. Caring Medical, nope, not that I've seen. Various clinics offering various types of upper cervical injections, dry needling. There's probably half a dozen or so at this point that have thrown their hat into the ring. The answer is no, they're not. Dr. Gillette in Barcelona couldn't find anything. Dr. Klingame, Barcelona, couldn't find anything. Klingame has published a few things on more theory of this is what I think is happening with things like a cold tethered cord, but nothing else, meaning no clinical data. Dr. Frank in Panama City couldn't find anything. Bolognese has 1 or 2 publications out there, and Henderson probably has the most of anybody. So of this list, and this list really should be about 10 or 12 doctors long, I kind of condensed it here. Only 2 of the 10 or 12, so let's say less than 20% are publishing anything at all about their outcomes. So let's talk about this PICL, patient outcome flow. So you got a PICL candidate. That PICL candidate can be a good candidate for what we do. They can be, a less than good candidate down here, in which case we may be trying the procedure because we know they may not do well, but they don't have many other options. And then, they're such a poor candidate that we're not even offering their procedure. We're actively discouraging them to do something else. So of these two categories, there's 4 different things that happen. The vast majority would return for more than one procedure, and that's this analysis. And then we've got obviously the one and dones, people who did well enough with their first one where they're not coming back. And then we've got people who haven't returned, but they plan to, but maybe due to finances, they're delayed. And then the people who have just no improvement at all. And of those people, I usually tell them, listen, if you've got no improvement from a single procedure, then in my experience, there's about a 60% chance you'll get improvement from a second procedure. And some of those people take us up on it, and some of those people decide to go other directions. So this is what we're talking about here today. So this was the list I posted on the PICL sub here. And as you can see, it includes people who are seen for their first PICL, and that's where the number is 0 here, which is the number of PICLs prior. And then includes people who were coming in for second or subsequent PICLs. So lots of information here. Now, as you can see, when I first started this, I wasn't collecting as much info. And as time went on, I started to say, well, this could be really interesting. So let's just start collecting as much here as I can in summary form, meaning that these are my own personal notes for my own personal purposes. But there's a lot in summary form here that you can obviously take a look at. So the first thing would be just looking at patients who are just coming in for their first PICL. As you saw up in here, I didn't really record much as time went on. I did, so these are interesting to review here. Thrown off a horse, centrally sensitized. That centrally sensitized means that they're a less is more patient, and they're worse since seeing Caring Medical. And then this was some information I had recorded early on about how the procedure went, which then got moved into a different category as time went on. There's another one seen for first PICL. This patient is status post Chiari decompression. Chiari decompression helped for a year, then overall the patient got worse. Not uncommon with Chiari decompression, at least for patients that I see. They had a C3-4 retrolisthesis, and there was no viable rectus capitis posterior minor because it got removed in the Chiari decompression. This one didn't get much detail. This one did, seen for first PICL. Again, another Chiari decompression. The surgery relieved the patient's left arm symptoms, but caused other disabling CCI symptoms. Again, a very common theme I see with Chiari decompression, where certain things get better, certain things get worse. Why do certain things get worse? Because they're more unstable after the decompression. So if they have a CCI problem, then the CCI part gets worse. Severe mechanical apnea, and this was basically just some procedural information from the procedure where I discussed with the patient's mother to see an ENT doctor because the patient had very large tonsils. We got it all done, but it was a little bit of a struggle because there was a bad airway during the procedure. Seen for PICL, severe type 2B, patient had 8 prior Perlo sessions in Caring Medical, was unresponsive to that. So that's why I'm seeing this patient. Then this one injured in a rafting trip, re-injured on a ride at Disney, generally feeling better, but severe type 2B and concerned about further re-injury. So this was a person who is fairly high functioning at this point, but every time they try to do something that's the least bit out of the ordinary, i.e. go on a ride at Disney World or go on a rafting trip or go on a boating trip, they get thrown out, and it's weeks and weeks and weeks of recovery. So kind of no way to live if you're trying to get out there and do things. Now here I blanked out the opposite. I blanked out the folks that are coming in for their first procedure. We're now only looking at patients that came in for a second or subsequent. So this is for one prior PICL, 80% improvement. There were improvements in DMX overhang. This person had decided to repeat their procedure, and 100% improvement on the right in DMX overhang, 20% improvement on the left. And then this is just some procedural information from me, which later got copied over to another category. 2 prior PICL procedures, 50% improvement, now holds for 3 months versus 3 days prior. And this patient had some fairly severe IJV stenting issues from the UK. And I think I did a video about this person. And if you go to my YouTube channel, you can see that. 1 PICL, 20% improvement, large bursa. So this was, again, just some information that I had put in about their procedure. 3 prior PICLs, 80% better. Third was the EPICL procedure. First and second were not EPICL. There's an old C5 compression fracture in this patient, so they have problems in their lower neck, and there's a large lower neck component going on here. This patient, 3 prior PICLs, 60% improvement, still locks in the right C1, C2. The prior PICL, which I think should be number 2 here, didn't look like an EPICL. So this will be the first EPICL this patient's getting. Next one prior, 10 to 20% improvement, but severe improvement in neuro symptoms, 50%. Patient states, I was in rough shape last time. Now the severe flare-ups are not 24/7, but only with specific activities. This patient had 1 prior PICL. She's a mess. She's got lots and lots and lots of problems in multiple areas of her body. Had 0% improvement, but reduced her opioids substantially from 50 to 60 milligrams. So that's from 5 to 6 high-strength Percocets a day to 1 to 2 high-strength Percocets a day. Now this one here had 3 prior PICLs, 50% improvement, has had multiple body parts treated. So neck is only really 1 small component. DMX overhang improved from 5 to less than 3. 1 prior, 70% improved, able to work out in the gym, no cervical use collar now. So this is an interesting one here because this was a higher level patient. 4 prior PICLs. So this is a rare 5th PICL person, 70% improved, but still gets left-sided symptoms went out, needs to start ramping up strengthening, which they hadn't yet done. 50% improvement overall, increased activity, holding longer. 75% improvement, that's from 3 prior. From 1 prior, 75% improvement, no longer needs a cervical collar, has returned to the gym, couldn't do the gym before. 1 prior, 50% better, but this is mostly for POTS and fatigue symptoms. So this is an interesting one. This is an atypical patient down here. So her POTS, so the frequency of IVs for POTS is down 50%, less fatigue, and then 1 prior, 40% better in the neck. So as you can see, pretty interesting, pretty good stuff going on here for these people. So improvements of these people coming back into the clinic, an average of 51%. The mean is 50%, 28% per PICL procedure. And then this just talks about what I did there. And basically all of these 3 patients were reported this way, including the woman who reported 0% but had dramatic reduction in narcotic use. And the 10 to 20% improvement is 15. This patient had reported a 50% improvement on anomic symptoms, but I only recorded it as a 15. So it gives you an idea of how that went. So I think that's all I have to discuss for today. Let's start going to some questions here. Let me get rid of this. Okay, questions. Andre, follow-up from last week. Should we get a DMX with rotation if we have a lot of extra? There is no such thing as, well, there is a DMX with rotation. I don't look at it. I don't consider it an accurate way to look at this, so I don't think you need to do a rotational component, no. Andre, you mentioned that if extending arms forward against the wall with wrists in extension produces compression-like symptoms. Yeah, certainly may be some thoracic outlet syndrome going on there. Andre, how can one get TOS diagnosed and how does it relate to CCI problematics? So that would be on physical exam. That's how you get TOS diagnosed. How can we best distinguish between various types of TOS? That's on clinical exam. Lorinda, the video is breaking up pretty bad. I didn't see that on my end. Is anyone else seeing video problems? If you are, put that down in there so I know that. But so let me know there. But just trying to figure out, is it on our end or is it all on the receiving end? Caleb, what is the success rate at treating symptoms for this? I've had neck issues my whole life. No history of EDS, though my doctor thinks I'm hypermobile because of my CCI, but who's to say it couldn't have happened due to injury or wreck, developed forward posture over the years, which led to neck pain and cracking. And a few months ago, things got worse and developed dysautonomia symptoms. This related to CCI. Yeah, Caleb, I would need to know exactly what kind of CCI you have. Again, our mantra here is you need to get typed as to what kind of CCI you have. And then from there, you would get specific injections to treat that. So I don't have enough information to answer that question, regrettably. So you would need to tell me your CCI type and what else is going on there for me to get some sense of how to answer that accurately. Let me take a quick second here and one second here. Okay. So everyone, first thing I want you to do is to like this where you are, because that's how patients find this. If you found this and you're getting a chance on a Sunday morning to ask an expert in this space about your problems, that's something that only few patients will have the opportunity to do. So pay it forward by liking this video, because that's how other patients can find this content, and they can find out about this Facebook Live, and they can join in and start asking questions. So do me a favor and do that. This is also the PICL subreddit. We've got 287 members now. So join Reddit if you're not on Reddit. If you are on Reddit, then join the RPICL. I answer questions on here 7 days a week. And basically do what I'm doing now, but more formally. Andrea, is there an enterosthesis on C3-4? Is this the case where prolotherapy and PRP can help or something else? Yeah, so C3-4 enterosthesis, that means that 3 is forward on 4, is something where prolotherapy and PRP can help, just treating those posterior ligaments, the supraspinous, interspinous ligaments. It's been advanced by Harry Winston. What is the average number of PICL procedures needed? That's 2 to 4 PICL procedures. Now, that doesn't mean that some are not one and done, some are. And then on the other end of that equation, some are more than 4. Caleb, I also see that Dr. Ross before, also should I see Dr. Ross before coming to you? I don't know who Dr. Ross is. If you mean Dr. Hauser, maybe, let me know who that is. Again, I don't know who that is. Elliot, is multiple PICL always going to be lower risk than a fusion? Yeah, absolutely. I don't think there's any comparison there. Just you have some example for upper cervical surgeries like this, the likelihood of ending up in an ICU is somewhere between about 1 in 10. The likelihood of having a severe life-changing complication that will require substantial ongoing medical care because of that complication is about 2 in 10. So those numbers are nowhere near that for PICL. So yeah, there's no comparison there. Andrea, video was more or less fine for me. Gotcha. So it would have been a local problem there. Christy, is cryoderm an okay product to use during the initial inflammation period? Cryoderm. That's a good question, Christy. I don't know what that one is. Let's see what that one is. Cryoderm. It looks like it's just a cold spray, right? Yeah, so I think that's fine. Just using cold spray should be okay. Elliot Smith, have you seen patients who see great improvement from a PICL but later decline? Usually not the case. Usually they hold on to that. So I'm sure we have, but it's usually something else that has occurred, i.e. another car crash, etc. Thanks, Lindsay, for the information. Thanks, Elliot, for the information. Robin, in my country, there is no access to PICL or POLO treatment. Stem cell therapy is the only available treatment. Can AI and CCI be cured with stem cells? Yeah, Raman, the problem is not what's being injected, it's how it's being injected. So that's sort of the issue, meaning that if your country is sophisticated enough, for instance, to offer PROLO, then it's very unlikely that they're going to be sophisticated enough to put stem cells in a place that are going to help. So that's the issue there is not so much what's injected, although that can sometimes be important, but how it's injected. So just putting stem cells in the cervical muscles probably not going to do much for craniocervical instability. So be very, very careful there. You would need X-ray guided, contrast confirmed procedures. And if it's in the upper cervical spine, which with digital subtraction angiography, or you're probably wasting your money. It's been advanced by Sherry Scott. I met with some recently, insisted that CCI was caused by an allergy. That seemed ridiculous to me. I invited her today, but don't know if she will come. But thinking of all the people out there suffering, yeah, no, I don't think it's caused by an allergy or anything like that. Again, I think what can happen is we see people who may have allergies, or maybe it's an EDS person who has MCAS, and being an EDS person has MCAS, they're trying to relate their MCAS to their CCI. But there's lots of patients who have HEDS who have MCAS who don't have CCI. So the problem, I think, is when we get into this mindset of trying to connect all the dots, sometimes the dots make sense to connect and sometimes the dots don't make sense to connect. Moha, doc, has any one of your patients got rid of tinnitus after the treatment? Yep, that's a pretty common thing, but you got to remember that tinnitus has to be due to craniocervical instability because that's what we're treating. Thanks, Carol. Nake, we had one patient organization with 2 PICL and was in bad shape and a lot of symptoms. When she had done intracellular testing, EDP check, had treatment with vitamin minerals, she became a lot better, new person. Kind regards to Norway. Well, thank you, Nake, for that information. But I think what you bring up is important, right? You know, the goal of this procedure is to provide a base for stability. And if you have a base for stability, then from there, you can do other things. So there's a guy online who had a single PICL procedure, couldn't work out before. After the PICL procedure, now he's rehabbing like a maniac. Well, that's great. That's what this procedure is supposed to do. Now, you can certainly say, wow, I got better because of rehab, but you couldn't rehab before the PICL. So, again, important to realize that the goal for PICL is to set you up with a ligamentous base of support, so then you can finish the job yourself, so to speak. That might be with rehab, that might be with other treatments as well. Caleb, I have cervical instability with C1-2 and cranial cervical, so to your team, just waiting for a response. Yeah, Caleb, so that if it's C1, C2 overhang beyond a certain amount, then that would get through the pre-screen, and then we would have to get on a telemedicine and decide what's going on from there, and then we can tell you whether or not we can help and what care looks like, etc. Austin, are there long-term plans for the PICL done in places like Atlanta with Dr. Chris Williams? Not Dr. Chris Williams, because Chris Williams is, as far as I know, has moved his practice down to Grand Cayman. So we won't be offering the PICL in Grand Cayman just because it doesn't make sense in that kind of island setting. Now, there are plans to move the PICL into other clinics around the country based on the qualifications of those doctors. So we're in discussion right now with the Florida clinic to do that, but that's going to take a lot of training. If you're interested in finding out about how that's going to work, go to my YouTube channel, which I have up on the screen right now. And I'm typing in PICL certification here. And this video that comes up right here, a physician PICL certification program, is the one that you would want to watch, because that talks about the whole certification program that we're going through. And it's going to be quite intense, and it's going to require a lot of commitment on the side of the doctor to be able to do this procedure safely. Right now, there is no one outside of Colorado that offers a PICL procedure. There's no one we've trained to do the PICL procedure, but that's about to change. Linda, do patients with a artificial disc replacement generally see improvement? ProDisc 3 through 7, still no curve, was doing well until I fell on hands and knees on concrete 4 months ago. From following her videos, cervical plexus type headaches, also can't sleep on my left, equals extreme symptoms, hoping to see Dr. Rosa soon, and then if I'm a candidate, I'm in Ontario. Yeah, so Linda, the biggest concern about ProDisc and ADRs is that despite the marketing, and the marketing is if you get these ProDisc things in, or if you get these artificial discs, then that'll allow motion, and some motion is allowed, but they act like fusions, meaning that if we look at adjacent segment disease, meaning the amount of arthritis and wear and tear occurring above or below the fusion, that rate isn't changed by getting artificial disc replacement. So yeah, it sounds like if you're from C3 through C7, then you have probably what's called adjacent segment disease higher up. So that would be at 2-3, 1-2, 0-1. Those are these segments that cause craniocervical syndrome. So that's really important for us to know. Now, the problem is I can't undo those discs. They're going to act like a fusion, and you're always going to get more force up there. I can stabilize things. I can treat the areas that are complaining and causing symptoms, but you're in one of those categories because you had these lower neck fusion-like things, these artificial discs, that you're probably going to need some ongoing care as the years go on. So anyway, long story short is, yes, we can probably help. We see patients like that all the time, but there's going to be some caveats there because of the prior surgery. Guys, if you are on YouTube or Facebook, please like this video. And that's because that's how other patients are going to find it. If you found it, that's great, but we need to get other patients to find this. That's one of the ways to pay it forward in the CCI community, because other patients would love to be here getting their questions answered, but they don't know this exists. So the only way they're going to know it exists is if you like the video. Dr. Rosa. So Caleb, you had asked another question up here. Let me make sure I'm following the thread here. Oh, Dr. Rosa, should you see Dr. Rosa? Yeah, Caleb, it's wonderful to see Dr. Rosa before coming to see me because that provides valuable information to me about what's going on. Now, not everyone can afford that. So obviously it's not a requirement, but if you already have that planned, I would certainly do it. Liam, have you seen a dramatic change in outcomes for people with type B with the new EPICL? Yeah, Liam, I think I am seeing that. We're going to look at that in the formal analysis, but yeah, I think I'm seeing that, and it makes sense. We're getting far better coverage of the dense band of the alar ligament. And the other thing that's happening with the new EPICL procedure, which is super interesting, is we're now able to get that coverage in patients that there's no way, even just a year or two ago, we would have been able to document that we were in that ligament because their anatomy is strange or different. For instance, I saw a patient the other day whose alar was extremely low in a very unusual spot. Using the new EPICL, I was able to see exactly where the dense band was located, which I wouldn't have been able to do before. And we got it. And there's no way, even a year and a half ago, I would have been able to get that alar. It just wouldn't have been possible with the PICL procedure as it was being done. So makes sense, but the answer is yes. I think that's going to happen. Ezra, can HEDS patients benefit from PICL other orthobiologic procedures at your clinic? Yeah, we did this. So if you go to my YouTube channel and you type in EDS under my YouTube channel here, you'll see PICL outcomes for HEDS or EDS. There's a bunch of videos on that. And yes, there is no difference in the end between EDS patients and non-EDS patients when it comes to PICL if those patients have craniocervical instability. And then, yes, we treat all sorts of other parts and pieces in those patients. So we're constantly treating shoulders, knees, hips, SI joint, etc. Elliot, does every doctor at Colorado Clinic now perform the EPICL or having you as a doctor an advantage? Yeah, Elliot, so every doctor does now that does PICL at our clinic, and that's primarily Dr. Pitts and Dr. Schultz have been updated to the new EPICL. And that, is easier, obviously, to do within our clinic, right? That's, hey, I've got an interesting case here that demonstrates how this EPICL is different. Go grab Dr. Schultz and bring him up and let me show him what's going on. Or go grab Dr. Pitts and let's go over this. Obviously, I can't do that with someone who's not in my clinic, and that's why it's really, really great to be a doctor in our clinic because you can get those updates and see in real time as I encounter the various parts and pieces of this new EPICL procedure. I can bring the doctor up and say, hey, look at this right here. And I can do that also with the rad tech. Our rad tech is excellent that is on this. And I can say, hey, Katie, you see that? Make sure that, and emphasize that when Dr. Pitts is up here, that kind of stuff. Michelle, my son was diagnosed with CCI via DMX. He has an appointment with Dr. Rosa in New York to align his access. Should this alignment be done before or after prolotherapy with you? I'm not quite sure if we're planning on doing prolotherapy. Again, Michelle, what we do depends on the specific type of CCI. So for example, if your son is diagnosed with type 2B CCI, then we would do a PICL procedure. If it's a 3A, then we might use something like posterior prolotherapy. So probably your son hasn't been typed yet. So you got to get that, and then we'll let you know, obviously, what happens there. But I would certainly see Dr. Rosa because Dr. Rosa is valuable from us for two different reasons. One reason is that Dr. Rosa has fantastic imaging for this kind of stuff. The other thing is Dr. Rosa is an advanced, very, very advanced upper cervical chiro himself. So he can frequently help patients find an upper cervical chiro in their local area and then give that upper cervical chiro the specific instructions on how to align. And that's something I can't do because I'm not an upper cervical chiropractor. So it's very, very valuable. Oli, can chronic inflammation cause CCI? Unlikely as a primary cause, could be a secondary cause. So Oli, what I mean by that is that we know that chronic inflammation does bad things for joints. We know that chronic inflammation can cause lots of problems. And if you, let's say, had chronic inflammation and severe postural issues over time, could you develop CCI due to ligament laxity? That's possible. So it's probably gasoline thrown on the bonfire rather than the ignition switch. Sonia, what do you think the likelihood is that a highly experienced Blair chiropractor could damage ligaments with the drop table technique they use for adjustments? You know, Sonia, all I can say is that we have seen chiropractic upper cervical ligament injuries. Those ligament injuries tend to be in a situation where it's more of a long lever, turn the head type manipulation without the right controls. I've seen less coming from Blair, but I suppose it's possible. Brian, does Dr. Merkel do PICL? Yes, Dr. Merkel has recently started to do PICL after extensive training at our clinic. Edgar, hi doc, my MRI showed the following. Yeah, Edgar, I don't know what it showed here, but I don't have that there. Alexis, can bloodshot psoriasis be symptoms of CCI? Usually not, Alexis. Emily, are you finding that the EPICL recovery is less traumatic and easier for patients? Yeah, someone brought that up the other day, that's going around the Facebook and other groups and threads. That could be possible for sure, just because it's a much more specific injection procedure. Edgar, yeah, Edgar, know what your MRI shows. Nothing here. Carol, submitted advance by Sherry Scott. I'm finally in a position to seriously consider this. How much time in Colorado would be needed? Sherry, a lot of that depends on if you're coming from international or domestic. If you're coming from domestic, then usually we'll ask that someone come in the day before, and then they come in the day before. They will come in that next morning. They'll get a hands-on evaluation. We'll then decide what we need to inject. And then from there, they'll do a bone marrow aspirate. They'll put to sleep for that. Then we'll process the cells. They'll come back in the afternoon. They'll get the re-inject for the PICL. They'll be in recovery. And then we'll usually want to make sure that the person is here that next day so that if we need to see them in the office, we can. So that's generally how it goes. Elliot, is there a limit to how many times a specific ligament can be treated? I've seen it had patients with injuries. Are the results less promising? Yeah, we don't have too many re-injuries, but we certainly get them from time to time. I don't think there's a limit to how many times a specific ligament can be treated, but there may be limits to the severity of the damage of the ligament itself. Lori, what is the likelihood of the transverse ligament, or is the transverse ligament, if an adjustment just will not hold? Atlas and C2 slide left. Remember how many times I get adjusted, giving up, getting adjusted, neuro symptoms bad. So again, usually that's not transverse ligament, although it can be. Oftentimes that's related to either accessory or alar ligament laxity or other things. So transverse ligament possibly, but usually other ligaments. Linda, thank you. I appreciated your thorough explanation. I wonder if it would be possible to do a telehealth to discuss without the prior trip to Dr. Rosa, as I have no caregivers, family, and the logistics, and at the mercy of finding someone to get me places, which is a struggle. Probably be easier to come to Colorado, get everything sorted out there, understand if it's not an option. Yeah, Linda, that is an option for sure. So that means that you would go through ISIS. Let me, so yeah, just go to the clinic, and the clinic website is Centeno-Schultz.com. And if you go to this make an appointment, you can ask for ISIS, and ISIS would be the person that would set up a telehealth to start that whole process. Lindsay, is it possible to higher dissect the TA nerve and or glossopharyngeal nerve, or is it best to treat the trigeminal nerve? You know, Lindsay, it all depends on which nerve is involved, right? So we've got to get a specific diagnosis of which nerve is involved, and that's the nerve we would treat. Now, when it comes to some of these will just get better if we reduce the instability. So realize that, you know, it just depends on that nerve. Guys, again, I'm going to ask you if you could to like if you're on YouTube, or like if you're on Facebook. The reason we want to do that is to make sure others can find this video. If you found it and you have the privilege of asking an expert on a Sunday morning about these things, I'd like other patients to have that same privilege, and we want to pay it forward in the CCI community. So please like this video. Alexis, thank you, Alexis. Yes, I work hard for sure. Now with the new PICL subreddit, it's really a 7-day-a-week job serving the CCI community, because you can see there's hundreds and hundreds and hundreds of questions on here, people posting pictures of their imaging. And I mean, this thing just keeps going on. And now it's like at 300 or 400 questions answered. So, you know, consider joining this Reddit group, because it's a great place to ask questions. I mean, it's not even going to come close to being the end. I think I'm only back about 2 weeks. This thing's been going on for months and months and months. As you can see here, hundreds, maybe 500 questions so far have been answered by me. So please join this subreddit. I don't put up with any craziness on the subreddit. So if you're concerned about Reddit in general, I get it. Some of these subs are out of control. And there's crazy stuff that goes on, and there's crazy folks on some of them. But I don't put up with any of that on my sub. So it's a safe place where you can come and ask these questions. Again, I'm only back 1 month here, guys, on these questions. So there could be 1,000 questions by now, maybe, that I've answered. I don't know. It's a lot. Emily, have you ever treated people with PICL with incomplete SCI or suspected incomplete SCI without radiographic evidence? Yeah, Emily, that's an interesting question. As far as an incomplete spinal cord injury, you know, I think that there's a really nice article by Jim Elliott on that concept, and that is that there are probably more incomplete spinal cord injuries out there that we recognize on MRI. And what I mean by that is that what Elliott has talked about in using very advanced imaging, what they found was that a lot of chronic whiplash patients had actually evidence of disruption of the spinal cord fibers, but you couldn't see it on MRI, and you needed very advanced imaging that's only available from a research standpoint to see it. So there are probably patients out there in the chronically injured whiplash population who have incomplete spinal cord injuries. And so, yeah, they're certainly a part of our CCI population as well. Now, realize that we can do things like treat irritated nerves, treat joints that got damaged, reduce the instability, and that's going to give you a certain amount of relief. I can't fix your spinal cord injury, however, and so it's going to depend on the amount of issues you have from that spinal cord injury. But I would really encourage you to look up that paper by Jim Elliott. So if we go to PubMed, maybe I can look it up for you, because it's kind of a game changer and didn't really get noticed very much. Yeah, so this is it right here. This is a really good one to look up, because I think it'll give you a little bit of hope and maybe make you think, maybe I'm not crazy. Maybe I really do have an incomplete spinal cord injury. They use some very specific MRI techniques here to actually dive into whether or not there was evidence of spinal cord injury when these patients had been told that there was nothing wrong with them. And they found that a lot of them, when they looked at this very advanced imaging technique down here, were able to find evidence of spinal cord injury in just the average person who had chronic pain after a motor vehicle collision type injury. So this is one you should look up and maybe share with your doctors. Liam, can eye issues like lazy eye issues worsen with CCI? Certainly CCI can impact, Liam, the ability to control motion or eye motion and eye tracking. And so, yes, it would probably make sense that could worsen a lazy eye. Andrea, sorry, I might have misunderstood you. You mentioned that you will be on sabbatical this year. If yes, how long? Yeah, I'm on sabbatical every year from May 1st approximately June 15th. And then on the other side of the season, the summer season, during the fall from September 1st through October 15th. So those are times I'm out of the clinic. Now, I still do work when I'm out of the clinic. For instance, I'm still going to be answering questions on the subreddit. So that's something I will do. My question answering may not be as snappy when I'm on sabbatical. So I might do it a couple times a week and catch up and do 20, 30 questions at a time. But I will be doing it. And then you'll be seeing, I am hoping, the YouTube shorts on a daily basis as well. And as you can see, I've got lots and lots of YouTube shorts now that come out every day. So those are two things you'll be seeing. And then I'll also still be doing once a week, I'll be seeing patients via telemedicine. So, I'll still be doing some things. I just won't be in clinic. Carol, it's been advanced by Harry. Are there any activities we should avoid because they could cause problems with CCI patients other than activities that flare us up? Yeah, so I think, Harry, if you were to go to the YouTube channel and if you go to videos, and I think you could probably just type in rehab here, but let's see. Yeah, the rehab video series comes up. It goes through all of that. That's these guys here. So it goes through all of that in detail. Raman, I used to do weightlifting exercises. I took amoxicillin and other antibiotics for my stomach ulcers. After that, I got all this into CCI. So can antibiotic resistance cause CCI? Probably has nothing. One probably has nothing to do with the other. Again, realize that, we have patients that are taught many times by the alternative healthcare system that everything has to have a cause, right? If you take an antibiotic and then all of a sudden you get sick, it has to be the fault of the antibiotic. And in my experience, it's usually not, right? Patients were probably going to get CCI symptoms anyway, or maybe the sickness itself caused an increase in systemic inflammation, and then that led to CCI becoming symptomatic, but they had CCI before. So unlikely there. Okay, guys, any other questions for me to answer? Give it a couple minutes here to see if there are other questions that are out there to answer. I think because of upcoming holidays, we probably have fewer people on here actively, but any other questions I can answer, please put those in now. Looks like Andrea's got another one. Coming back to nerve compression when extending arms. If making a fist reduces or annuls these sensations, is it still indicative of TOS or something else? That's a good question. I'm just wondering whether making a fist, if I make a fist, for example, one of the things I do is I tense, my entire arm and its stabilization system So my guess is making a fist is simply allowing you to have better scapulothoracic stabilization. So it still then would look like TOS. So I'm guessing that's what you're experiencing there, Andrea. Let me give, again, a plug for a couple things. One is to join and subscribe to my YouTube channel. As you can see here, I've got hundreds and hundreds and hundreds of videos that are long form. I do a daily YouTube short here answering questions. So that's Chris or at Centeno Home at YouTube. Want you to also spend some time and join the PICL subreddit. We have 287 members now, and that's climbing every week. I go on there and answer questions for patients. And then in addition to that, like the video where you are, whether you're on YouTube or Facebook, that's how people find this content. So that's how you pay it forward to other patients that are struggling. Andrea, hands are still an extension of making a fist. Yeah, I think that's what you're doing, Andrea, there. Edgar, so these are your MRI findings, mild disc degeneration. Yeah, no, so Edgar, there's nothing about a static MRI, and certainly a static MRI report, or it's very unlikely that that's going to diagnose craniocervical instability. So your MRI results for a static live face up and tube MRI really aren't any different than the average person walking around the street who may or may not have neck pain. In order to get diagnosed with craniocervical instability, you need specific movement-based imaging. So that might be a seated MRI with flexion and extension, or that might be a digital motion X-ray. Or it might be specific movement-based X-ray views, but a static live face up in a tube MRI, and especially as read by the average reading radiologist, is not going to show whether or not you've got craniocervical instability. Now, there certainly are, my guess is I could probably look at your MRI and find things that might support circumstantial evidence of CCI, but then it would have to be confirmed with movement-based imaging. But realize, again, the average live face up in a tube neck MRI is not going to really be focused on diagnosing craniocervical instability. Ezra, so I pressed the like button today, as I always do, and other weeks notice that although the like button is highlighted, did not register the like. Yeah, I don't know. Ezra, maybe that has a specific, maybe there's something specific going on there. I don't know why. Andrea, thanks a lot. Really great for all your time and where the dedication you show. Thank you, Andrea. Thank you for recognizing that. Again, I try hard to work for the CCI community to make sure that they get their questions answered and they make informed decisions. Whether or not I ever end up seeing you as a patient doesn't make a difference to me. Thank you for the stream. Thank you. Not CCI related, but I saw today a funny little tariff exchange on the PICL subreddit. There was someone who asked a question of, it's in here someplace, whether or not the tariffs were going to affect people coming into the country. I have our trade war and CCI treatment. Here it is. Do you foresee any challenges for international patients in getting CCI treatment with the trade war that the USA is waging with the world? I didn't see anything like that. Oh, this is turning into, I may have to get rid of this question because this is turning into kind of a back and forth on politics, and this is not a political, not at all a political sub. So thank you for bringing that to my attention. Ezra, thanks so much for doing these streams. Very much appreciated. Thank you for participating. Casian, a lot of doctors use lidocaine to treat nerves. How is lysate more conducive to long-term results? So Casian, lidocaine wouldn't treat a nerve at all. It just blocks the nerve or makes the nerve not complain for a couple hours. So it's not a treatment for anything. It's just a way to shut down the nerve from a diagnostic standpoint. Platelet lysate would have growth factors that can help the nerve, so that would be a treatment for a nerve. Ramen, can infection cause CCI? I don't see any evidence as of today that's compelling that infection causes CCI. Liam, is strict bed rest recommended after the procedure? It is not. We want you to be activity is tolerated. Again, that's where those rehab videos come in that I've showed before. Asthma, if you press lightly on my C4, it pulls towards the base of the skull. Essentially, it's the feeling of displacement between the skull and the cervical vertebra. So if you press lightly on C4, it sounds like the spinous process maybe goes upwards towards the skull due to spasm. So if that's the case, then you're really going to want to get that investigated, see if that could be craniocervical instability, movement-based imaging, because that almost sounds like maybe you're pushing something out of place there, and then the body is responding with local spasm. Thank you, Ray. Yep, Lindsay, yeah, she was just giving me a hard time about doing these Facebook Lives on Sunday. I may change the Facebook Live to a different day because it probably is true that Sunday is not a great day for me personally, but I've moved into Sunday to try to improve participation. Linda, would a DMX from Dr. Beard be as acceptable as one from Dr. Rosa? Yes, I think either spot would be fine for getting a DMX. Edgar, thank you for your time working with the Regenix docs to find out what to do with my neck injury, as I may have some minor CCI. Sure, Edgar. Casey, is it universally true that rectolisthesis has to be treated with anterior injections? Yes, there's no other way to deal with a rectolisthesis because the ligament that controls that is in the front, and it's the anterior and longitudinal ligament down here. And then as we get up here, it has different names, but it's the same ligament. Asthma, how to differentiate between CCI and a subluxation. We differentiate them using CXA, BAI, BDI, and Grab Oaks if the measurements are normal and we have symptoms equal misalignment. Yeah, I did a whole video on that asthma. That it was just recently. So if you go to the YouTube channel, let's see here. That's right here. What's the difference between out and unstable? It's the one here that says out of place or truly unstable. So that should answer your question there. If you go to my YouTube channel under shorts, and then it is 1, 2, 3, 4, 5, 6, 7, 8, 9. So it's the 9th one down. That one should answer your question. Austin, I've been getting a lot of targeted ads lately of supplements that claim to increase stem cells in circulation. Yeah, I would say that's fiction, meaning that I don't know why you would want to increase stem cells in circulation, number one. Basically what happened, near as I can tell, I should do a video on this. This was the blue-green algae folks from way back, right? The blue-green algae folks were out there. They were pretty aggressive. It was a multi-level marketing scam where basically, someone up here made a lot of money, and then the second level made a little more money, and the third level made a lot less money, and the fourth level made no money. And sometime in the last 10 years, they figured out that they should market it instead as a stem cell supplement. But yeah, I would run, not walk away from that stuff because I don't see that there's any evidence that this would help you. There's probably no evidence that it even happens anyway. And this is just a rebrand of the blue-green algae folks. Who tried to figure out a way to rebrand. And you'll see that a lot. There's multiple companies that had products that weren't working, and then they rebranded them as stem cell activators, for example, and all of a sudden they started to sell. So be careful there. KCN, is there such a thing as anterior neck injections without the PICL? Yes, that's called a TALL procedure, so transcutaneous ALL procedure. Dr. Pitts does a lot of those down in here. Now, if we're doing the PICL, and if it's C2-3 or C3-4, we can generally reach that from the PICL and just get it all done at the same time. And then how do you inject the lower anterior neck ligaments? That's by coming in from the side here and doing something that looks like a disc access approach. Okay, guys, so we're just coming up on 10 o'clock. I've been at this an hour. I'm going to end it for today. Thanks so much for watching, and thanks for all the great questions. Do me a favor, like this before you leave so other people can find this video. Join the CCI subreddit. Become a subscriber on the YouTube channel. And I will be here next week. And then I think the week after that, or the week after that, I'm not quite sure yet here. Let's see. So I will be here next week, and then the week after that. And then the week after that is when I go on sabbatical. So there won't be any YouTube lives when I'm going on, or Facebook lives when I'm going on sabbatical, but there will be daily YouTube shorts coming out, and I will be answering questions, maybe not as snappy as I do now, on the Reddit thread, so the Reddit sub. So thank you for spending all the time with us today and participating. Again, your participation not only helps you, but it helps other patients because the more information we get out there about CCI, the more physicians start to recognize what's going on with it, the more patients can find their way through the crazy maze of medical care to actually get good care and get some results. And the more good information we get out there, the more we drown out the crazy information that you can find on social media and in discussion boards, some of it truly nutty. So thanks so much for participating in this, and have a great week. And I wish you all the best this week, and I'll be back next week. Thank you.